Hey everyone, and welcome into Pushing the Limits. Today I am super honored to have Dr. Carole Peterson with me. And Dr. Carole is, I think, the world's foremost thought leader on progesterone and hormones in general, really, and an absolutely mine of information. So welcome to the show, Dr. Carole. It's absolutely wonderful to have you here. Thanks for taking some time for us.
Thank you. The doctor might be honorary.
Well, you're a
But
pharmacist. You're definitely in my book.
okay. I would propose that I probably have done the equivalent of some PhDs, and
Exactly.
I have a lot and some medical stuff. I had wanted to go to medical school, but it didn't seem quite right, the timing or what was available. And in retrospect, I'm very happy because I avoided the propaganda that every medical student, actually pharmacy too, but when I went to pharmacy school, some of that was in its infancy. It's horrendous now,
Yeah.
and you go into a professional school and you're encouraged to forget everything you learned in biochemistry and physiology. In fact, I've had women say things to me about what their doctor said about hormones. And I said, will you ask him if he passed his biochemistry test or
Yeah,
not?
exactly,
Was he
because
at
some
the
of it's
bottom of his
basic.
class or her? Just
No,
the nonsense I hear some of the time. It's incredible. But it does speak to, this is an area and that is very much ignored in the educational system for medical professionals and women, and I will submit to you, men too, suffer as much from hormone imbalances and a failure for those to be recognized and fixed very easily. For the first time in our history, we have the ability to top off our hormones with the same hormone. Gives us some powerful tools. We know from basic physiology research what each hormone's supposed to be doing and how it's supposed to be doing it. So you can clinically identify shortages and excesses. We have laboratory testing. Now there are limits to the laboratory testing, but a tool, secondary tool, but I would say what's happening in the person's body is the primary diagnostic clue what's going on. And this big failure to recognize hormones can be easily in disarray, and it can be all the way through your lifetime. You can have shortages in hormones as an infant. And it should be part of every workup, every basic, you get a blood chemistry, but you don't get a hormone panel. Why is that?
yeah. Yeah, yeah. I mean, I just totally agree. And as someone who's been to hell and back with my hormones personally, starting off as a young girl at 12, 13, when I first got my periods for, having months of bleeding and not knowing why, huge pain. And the doctors, what they did, they put me on the oral contraceptive pill at 13 years old. And I stayed on that for decades because it balanced everything out, because it's a complete endocrine disruptor and takes away all of your own hormones. They didn't get to they put a band-aid on a festering wound, in other words, and then later on, infertility, fibroids, estrogen dominance, none of which I knew. And of course, I was an ultra endurance athlete too. So I completely stuffed myself as well, because I did extreme amounts of exercise through my own cycle out of whack, of course, which made the progesterone no doubt even lower. So I've been to hell and back on the horse cart in regards to my hormones. And I see so many other ladies going through this now in the perimenopause, menopausal time, and myself, going through menopause as well. And they're being the talk is always about estrogen. Oh, you've got hot flushes, you've got vaginal dryness, oh, you're not sleeping well. Oh, let's give you some estrogen. What's wrong with that picture, and why is that sort of, not the full story?
Okay, so some of this comes from the work of Dr. Jerry Lynn Pryor, and she's at the University of British Columbia. And she has a lovely website I'd refer you to called Cemcor, CEMCOR.ca. And you'd be interested to know that a lot of her research initially was done with very athletic young women blowing through their hormones
Yeah.
and being unrecognized. They would lose their cycles, they'd lose progesterone, ultimately lose estrogen too. She has another thing that she published, and she had great difficulty in getting this published. Women in their perimenopausal years, of course, there are exceptions, will have the highest levels of estrogen in their whole lifespan during
Mm.
those years. And couple that with losing ovulations. You can still bleed if you haven't ovulated. And so even that little bit is a mystery too. I've just seen just the client I talked to just now had a test result, and she was postpartum, but she had her cycles already, but no progesterone
Mm.
happening, no ovulation.
Yeah, that's yeah. And we are
So
always given
so
estrogen as a first call.
yeah. Okay, let me address hot flashes, because hot flashes is a big thing that women think they need estrogen for, and they sometimes even get some relief. But I think we have to look at it a little differently. Why are you getting hot flashes when you have the highest amount of estrogen in your body? Jerry Lynn Pryor just recently, in the last few months, published a study that showed 300 milligrams of oral progesterone took care of the hot flashes. And that's my experience too, that progesterone will help that. This is how I think hot flashes occur. A colleague of mine mentioned that um, her clients, some of them had some continuous glucose monitors,
Mm-hmm.
and when they had a hot flash or a night sweat, their blood glucose dropped to 40,
Wow.
30, extremely low levels. And this causes adrenaline to shoot up, to bring back your blood glucose. And I think it's this combination. Progesterone's a moderator of adrenaline. It will, put the brakes on excesses. So you have not enough progesterone, shoots of adrenaline with insulin glucose dysregulation. I recently heard that the incidence, at least in the US, of insulin resistance is 9 out of 10 people show signs of
Wow.
insulin resistance. So this is all tied up into our diet, our
Mm-hmm.
stress. And recently I've been investigating how alkaline you are, which also ties into early problems with the pancreas and the kidneys. And so I think that might be a little tiny piece of it. So when I'm working with clients, I have to take a multifaceted look. It's not just, okay, you're getting menopausal, we'll give you progesterone, we'll give you estrogen. Hello, we'll see you next year. And that's the story. No. In fact, many women are getting worse because of their doctor's treatment.
Mm.
Uh, I was working for Women's International Pharmacy till 2020. I got laid off with the COVID stuff. So I
Mm-hmm.
went to Facebook and I
Say no
found
more. Yeah.
I found hormone related groups, and I loved it because they had exactly what I wanted. How are we failing women and men? And we are, and there's so many women there with having gone to multiple practitioners, still suffering. And I started staying up to 2 or 3 o'clock in the morning answering questions. I was just
Wow.
so taken up with how many women out there were having some real problems that I saw that there were pretty straightforward solutions for. And I had to quit that because I was losing a lot of sleep. So
Yeah, yeah. Get yourself sick.
I know.
Yeah.
But
Yeah,
I still try to pop over now and then. And it sort of started um, getting me doing more podcasts and things
yeah,
because the Facebook admins reached out to me, and so I started doing more and more things. The one thing that really threw me for a loop, and I'll say those women who are told that they are PMDD, premenstrual dysphoric disorder. That's really the emotional side of PMS. Katarina Dalton in the 1950s had already described it. It wasn't until the late 1990s that the drug companies in the US wanted to find a new approval for the SSRI antidepressant drugs.
mm,
And they railroaded this
hmm,
diagnosis through the FDA. And they had some study that showed like 50% of women had mood improvement with these, but it's worse because now at the time, I was working at the compounding pharmacy. All those symptoms disappear with progesterone. And I said, well, this will never fly. I was so mistaken. One of these groups from the UK about PMDD reached out to me and said they started using more generous amounts of progesterone and their lives were transformed. And women with these symptoms were first line were these antidepressants, don't work, even worse, gonadotropin blocking drugs, which shuts off your pituitary signaling to your adrenal glands and your ovaries. And then you put estrogen back and you make the poor woman worse. And when all that fails, birth control pills sometimes tossed in there too. When
mm.
all that fails, you're encouraged to get a oophorectomy because you should not use progesterone. You're sensitive to it, it's your enemy. And it's the very thing you need. And what's horrifying is I now find this philosophy is entrenched. They entrench this in medical practice. So women in this, I would call them the canaries of this whole kind of situation that we find ourselves in with perimenopause and PMS, infertility, where we don't have the right answers. We have contrived protocols being taught in medical schools and entirely without good results.
Yep, and aimed at selling more SSRIs, which they've successfully done, which is huge. When
Just
progesterone should have been the first port of call for a lot of these ladies, and what I'm saying, I do a lot of testing. I do Dutch testing, which has, I know now, its limitations in some ways, and then serum testing has its limitations in some ways. But what you're seeing very, very often is low progesterone levels across the board. So that seems to be younger and younger women. It seems to be even in their 30s that they're starting to have a drop off of progesterone. And we tend to have estrogen is sort of in the perimenopausal years, sort of going up and down and is all over the place, and it can be very high. Then we've also got xenoestrogens in the environment that are, the glyphosates of this world, the things that we are all exposed to all of the time, which are xenoestrogens. So they act like we can't measure those really, can we? And
no.
then we've got a drop off of progesterone happening at the same time. So our progesterone's going steadily down or dropping off a cliff. Estrogen's going all over the show. Plus, we've got these xenoestrogens. And what we get is a net effect of estrogen toxicity or estrogen dominance. And then you're getting fibroids, you're getting endometriosis, you've got infertility, you've got all of these problems that could be addressed with progesterone at higher levels than what we're currently doing generally. Most women, when they get estrogen, they might get 100 milligrams to protect the uterus. That's the sort of normal dose, right? 100. If you're lucky, you might get a 200 milligram dose to help with sleep or something like that, which seems to be the effect. But when I started to study your work and your lectures and things, I was just like, holy crap, this isn't touching the sides for a lot of ladies, and it certainly wasn't for me. And I've been experiencing all sorts of swings and roundabouts with my hormones, as I said, for many, many years. In When I was 48, I had massive fibroid problems. Like, I had one huge fibroid that was the size of a grapefruit that had fallen into the cervix. So I was having incredible pains, like, bleeding, like, too much information, people, but I bled for an entire year without a day off, right? And I had to have
Oh,
blood
that's
transfusions after blood transfusions, and they said to me, you have to have a hysterectomy, you have to have a hysterectomy. And I was going through IVF at the time. I was like, I am not losing my uterus. I don't give a shit what you tell me. I'm not letting you take it. And they said to me, well, you're going to die if you don't have a hysterectomy. And I stood my ground. And I didn't have a hysterectomy, and I didn't die. And I worked out which of the fibroids had to be taken out, and I've convinced a surgeon to take just this one particular pedunculated
mhm,
fibroid that had collapsed into the cervix, and took that out. 10-minute operation. Bob's your uncle. Didn't have any more
mhm.
problems after that, right? And this what I see is hysterectomy after hysterectomy. I recently had a friend who nearly died after having an operation, and they don't know what happened to her, but she unusual situation. This is not an operation without its risks. And then the consequences of having a hysterectomy, you're instantly going to go through menopause. And they say, well, if we leave your ovaries, you're still gonna have your ovaries. It's like, most of the time they're not going to work. If you watch an operation of what they do with your ovaries while they're taking out your hysterectomy, which I did, I went and watched operations online to see what is a
Oh, wow, I
hysterectomy.
haven't done that. Yeah.
Yeah. Well, I wanted to see if I'm going to go through this, I want to know exactly what they're
Yeah.
doing, right? Because I like looking things in the face and facing up to them. And I'm like, hell no, that's not happening in my body. And um, and so, but we do hysterectomy as a sort of almost a standard, just, oh, you've got heavy bleeding, oh, you've got fibroids, oh, you've got this, oh, you got that, oh, let's just take it all out. That is just a disaster, a health disaster for the woman. It instantly puts you into menopause most of the time, even if you've got your ovaries. And it hasn't dealt with the actual problem. And how many of these people could have avoided hysterectomy if they'd been given
I
progesterone?
think I think nearly all. Um,
Exactly.
I used to say maybe cancer, but now I'm going to say progesterone is going to be helpful for that. Endometrial cancer was I came across an article, University of California, I believe San Diego, and they were working on a project to introduce a test for endometrial cancer severity. And the test involved evaluating the number of progesterone receptors. And
Mm.
they observed that as endometrial cancer got progressively worse, the body had less and less receptors for the progesterone. In the discussion, in the preamble, it said, oh, we used to reverse endometrial cancer by about for 50% of women with progesterone. Hello. Hello.
That would have
And
been good to know.
and now that's not even offered. You go right to
Wow.
hysterectomy, no choice. You have cancer. Oh, this is a very treatable cancer. We'll just take out your uterus. And then worse on worse, you're sold the idea that after that you're going to need
You,
estrogen
you
and
need
probably
estrogen, you don't need progesterone.
you don't need progesterone. You ignore the whole rest of the body. Tell me how the Endocrine Society and the Menopause Society and American Association of Obstetrics and Gynecology, how dare they sit in a committee and ignore how a hormone works throughout your body? It's this is like
It's shocking. It's shocking. The progesterone does not just work in your uterus, does it? Tell people what it
no.
does. No.
No, it's all over. So we have a little misconception, and I have if John Lee were still alive, I'd have a little bone to pick with him.
Mm.
because, and he wrote a great book on progesterone for a basic first look at what progesterone does, the multiple roles of a remarkable hormone. Lovely book, lovely book. But John Lee said, "Oh, we only need 20 milligrams. So ovaries
Mm,
make 20 milligrams."
wrong.
And the interesting thing that happened with that is right about this time, I'm working in the compounding pharmacy. We're using large doses of progesterone to treat PMS, a la Katarina Dalton. And we set it at 100 milligrams 4 times a day with a progesterone and oil capsule. When that wasn't enough, we went higher. When a woman was doing pretty well in a particular dose, she stayed there, but she might have breakthrough, we called it, and she might need a rescue dose of progesterone. And we were doing lozenges and vaginal inserts, rectal solutions, all sorts of things. And I added up the milligrams at the time. The most I saw a woman use in one day to control all the symptoms was like 2,400 milligrams.
Wow.
And
Wow.
I've seen more since, but but we called it a breakthrough. So there was a health newsletter. Dr. Julian Whitaker published that Progest had come on the market. This is what a brand that John Lee recommended, had 16 milligrams of progesterone.
Tiny amount, which is a tiny, tiny amount. Oh,
Yes, and about a quarter teaspoon dose of progesterone. And he recommended that's all you needed. One dose of that, that's all your body made. That's all you should put on, ignoring the fact maybe you didn't absorb it
yeah.
in the first place, but there it was. And because this came on the market, uh, Dr. Whitaker was talking about Women's International compounding with hormones, and he directed people to buy Progest from us. We didn't even stock Progest. We hadn't even heard of the product. And so women, of course, we got it because we're getting all these women called for it. And then after a while, of course, they're calling back. They're not doing so well. Their symptoms are actually worse with that little dose. And of course, hey, we knew what to do. We knew progesterone works. And we would kind of guide them and give them our literature for Katarina Dalton's protocols, like using plenty of progesterone. We know it works. Later, I heard John Lee give a lecture, and he spoke about this complaint where women weren't doing so well on that low dose. And he goes, "Oh, just keep up with it. And in about 9 months, it'll be fine." So 9
9 months.
months when I know it can be an hour or so.
Wow. So you get instant relief when you do these higher doses. And then these tiny little doses, and these little doses can actually have, I think you called it kickback, or one of the Facebook groups called it estrogen kickback, where you're actually potentiating the estrogen and actually
Yeah,
making it worse when that you
yeah,
have a tiny dose. You're not balancing
and
it.
yeah, and I think some of that may have some adrenaline effects too.
Mm-hmm.
So I kind of at the first was thinking heart palpitations, panic attacks are estrogen related, but those really sound more and more like adrenaline, which progesterone
Mm.
balances too. The estrogen things that come up all the time are headaches, even new onset of headaches, terrible breast pain,
Mm.
fluid retention, and the anxiety is a big one, and that could be more adrenaline or estrogen. I don't know which, but these low doses can do that, and I think it's a horror show if you leave a woman in that situation. Like, what if your doctor's given you a prescription for 20 milligrams of progesterone to see you in 3 months, and she's like desperately trying to use this because it's supposed to help her, but she is terribly underdosed. And I think this is kind of a dead zone or a dangerous zone if you're magnifying your effect of estrogen and not balancing it. So what's the problem here? The problem is the estrogen is potentiated, maybe even the adrenaline is too. and you have this small dose of progesterone. So let's go back to John Lee and the ovaries. Yeah, they make about 20 milligrams, maybe a little more, the ovaries do. But your adrenal glands make it, your Schwann cells that make the myelin sheath around each and every
Wow.
nerve in your body, they make it right there and use it right there. We never measure it in any type of test. Nothing. You can't measure that. The brain makes it independently. The mast cells make all the hormones independently. If you're off balance there too, with not enough progesterone inside your mast cells, you're going to get histamine release. Um,
Allergies and all of that sort of carry on,
right,
itching and all
right,
of that. Yep. So that could be estrogen
exactly.
dominance as well. Yep.
Exactly. And then there's all the corticosteroids, which there's a great debate whether progesterone actually converts to cortisol or if the presence of extra progesterone allows pregnenolone to go that way and replenish the corticosteroid pathway. But we measure that. We measure that in some of the urine tests. You see the metabolites. You see women not only low in cortisol, but cortisone, the major storage, and then like 3 or 4 metabolites. They're like all getting zeroed out. And
Yep.
you've got chronic fatigue. You can't do anything. And so you're asking that little bit of progesterone to do all that work.
Yeah.
And
And
it's just not going to make it.
and it's just backing up there. So what is the relationship from progesterone and pregnenolone to cortisol? Because and what does cortisol do in the body, and how do you feel when you have low cortisol? And how does that manifest? Tell us that picture.
Oh, I love that question because I frequently give this advice. When you have low cortisol, you have fatigue so debilitating, you can hardly get out of bed. You have muscles ache, every muscle aches, every joint aches. What's that sound like? It sounds like the flu, right?
Mm-hmm.
Right. And I'll submit if you do have this and you do have the flu, what's happened? You actually William Jeffries did one study on this, showed ACTH, the stimulus to make more cortisol from the pituitary, is blocked when you're sick like that. You put
Mm-hmm.
in hydrocortisone, you can get rid of that in half an hour, an hour. Hydrocortisone cream 1% is available in the US everywhere. You can simply use that hydrocortisone and relieve that fatigue.
For the
So,
short term, because you don't want to do that for long, do you? Because of
well,
because you can get
there are
dependent on hydrocortisone.
there are people that have used it for great lengths of time. There's congenital adrenal hyperplasia, which you can't use progesterone. You've got to use hydrocortisone. It's going to be a lifelong thing, and you have to be exactly balanced. Dr. Jeffries probably was this kind of person. He used hydrocortisone 5 to 10 milligrams every 6 hours. He was
Hmm.
very keen on the every 6 hours. He himself used it over 30 years in that manner and sometimes increased his hydrocortisone according to stressors in his life where he identified his minimum wasn't helping him. I talked to him personally one time. He had an outbreak of shingles. He went up to 300 milligrams of
Wow.
hydrocortisone
Wow.
and went golfing and had an uneventful weekend. After 3 days of that, the shingles were
Wow. Wish I'd known that
healing
when I
up.
had shingles.
Was healing up nicely. So he had absolutely no problem with pain or quality of life, just went up. And he explained to me this is exactly how your body's supposed to work to address an onslaught like that. You would naturally have a big flood of hydrocortisone, and then as it passed, you could come down, and you can come down fast, unlike the synthetics like prednisone and
Mm-mm.
methylprednisolone. These actually shut your adrenal glands off and they've killed people. with giving them these drugs and pulling them off right away, and your adrenals are not doing anything. And that means
So hydrocortisone's quite different than prednisone and methotrexate and all of those ones. So hydrocortisone is that sort of like a more bioidentical form of the cortisol or cortisone?
yeah, it is. It's
Right.
entirely bioidentical. So
Right.
I kind of like hydrocortisone. Now,
Mm.
progesterone, as I said, in charts, it's one metabolic step away from cortisol, but there is an argument that it actually is being converted from pregnenolone, not from progesterone. And the normal charts don't actually show that. However, if progesterone is there, one way or another, it either helps you make more cortisol or it shifts so pregnenolone helps you make more cortisol and fill in all these deficits.
So if you've got people, if you've say done a Dutch test and we're looking at the cortisol and the cortisone levels, and you've got someone who's flatlining, they're not making a cortisone or cortisol awakening response, and they're not having that nice rise in the morning like we're meant to get our energy going, our melatonin down, and all that. They could really benefit from progesterone, pregnenolone, possibly, and even hydrocortisone, as well as maybe like adrenal glandulars and
Yeah.
adaptogens like ashwagandha and things like that. What about the
Lots of
person? Yeah.
salt, let's not forget salt.
Salt and vitamin C. Salt and vitamin C. Yeah,
Yes,
two
yeah,
other very crucial pieces. Yes, thank you.
and
Just interrupting your show to let you know about our Health Span Hacks course, How Not to Die. This is a comprehensive course created and produced by myself and world-renowned cellular health and regenerative medicine specialist, Dr. Elizabeth Yurth, founder of the Boulder Longevity Institute. Now, this course unlocks the latest on the science of anti-aging, longevity medicine, and cellular health, equipping you with the tools and the insights to improve your health span and vitality. Together, Dr. Yurth and I have provided evidence-based strategies to optimize your body and mind, empowering you to live a longer, healthier life. So enroll today at lisatamati.com and start transforming your future, or check out the link below in the description.
and
What if they're
B5.
high? Well, B5 as well. Okay. What about if it's high? If they've got high cortisol and it's staying high over the day and going up at night, which you often see that inverted pattern, low in the morning, high at night even.
Okay, so cortisol, it's not stimulating. You could be in a bathtub of this, it's calming. It's the adrenaline, and often the two track each other and sort of
Uh-huh.
balance. The high cortisol is trying to balance the high adrenaline, but you can get in this situation kind of what characterizes adrenal fatigue, that the adrenaline stays up and you exhaust all your hydrocortisone,
Cortisol.
well, and that becomes more and more deplete. At first it was high, but then it's down. One of the problems that I see in women having multiple problems is they have detoxification problems with methyl groups, and you need methylation to metabolize estrogens,
Mm-hmm.
histamine, and adrenaline. It's the primary pathway for adrenaline.
Mm-hmm.
So if you are low in methylation factors, you don't simply have them, and you have sluggishness in your liver able to use these, you have a problem getting rid of this. And I've talked to women, they literally shake. They have so much adrenaline, their body quivers during the day. They
Yep.
can't get rid of it,
Yep.
and it's horrifying.
Been there.
Um,
Hmm.
then I learned. I just learned this too a couple weeks ago because I was in one of the medical groups. Somebody mentioned adrenaline and creatine. And I go, oh, what's that about? And that's
It's a
a
methyl group.
supplement.
Yeah, I love
Well,
creatine. Yeah.
well, it's a methyl sink, methyl group sink. If you don't have enough, your body will make more creatine, using up your methyl groups, and then you can't detoxify. So why not supplement So you make
Absolutely.
sure
I'm a
your
huge
hormone
fan
is
of
safe.
supplement. I think everyone over the age of 40 should be on creatine from a muscle synthesis perspective, from a brain health perspective, from
Mhm.
a methyl donor perspective. I think 5 grams of creatine would be good for everybody to support our, methylation, which is such a huge thing. And if you've got SNPs in your methylation genes, of which there are a number, quite a few, not just MTHFR, by the way, then this is even more important because that's part of the detoxing, those processes to get your hormones back out of the body and do once they've done their job. And we
Mhm.
want that. And then you've got also beta glucuronidase. So if you've got a gut issue and you've got some dysbiosis in the gut, and you've got too high levels of beta glucuronidase, you might have detoxed your estrogens out, and then beta glucuronidase comes along and goes, oh, what's in here? Oh, estrogen. Oh, we're going to put that back out into circulation. And so if you have gut problems and gut dysbiosis and beta glucuronidase, it's too high, then maybe you're going to have to even double down on the lowering the estrogen, getting the progesterone levels up.
Right.
Because
Um,
it seems like progesterone is the balancing act, and if estrogen is too high because of environmental, the time of life, the menopause, up and down, then progesterone is the answer to pretty much everything.
okay, now you're going to see some uh, information. Dr. McCullough's promoting this in his new book and his website recently. He's following the um, writings of Dr. Ray Peat, who
Mm-hmm.
is one of the original progesterone investigators as a biologist. And Dr. Peat said prolactin, measuring prolactin, is a better measure of
That's
estrogen
it.
status than if you measure any of the estrogens directly. Now,
Mm.
does his status include all those xenoestrogens? Maybe it does, it doesn't. I don't know everything, but in a high estrogen state, prolactin goes up. Uh, Accompanying that high estrogen state is low thyroid functioning, which is
Mm.
what can happen when you overexpress estrogen anyway. You depress your thyroid functioning. So you can watch for increasing prolactin. So I would, if you're doing metabolic tests, I would definitely include prolactin. Now, is it the end all and be all? I think we have to look. Another clue I would look for estrogen status would be sex hormone binding globulin,
Yeah, yeah.
the carrier protein made by the liver, and it's stimulated by high estrogen and high cortisol too. So
Mm. And
it
oral
gives
contraceptives if you've been on those bloody things.
it can keep that sex hormone binding globulin up for years and years
Exactly.
after
Yeah.
your last pill. I'm very happy. I had a couple clients who took birth control pills for a long time. One was post 5 years, and her sex hormone binding globulin had returned to normal. The other one was 10 years
Wow.
after normal, but we don't really know. They've gone out a couple years as they've done their studies and see persistent high sex hormone binding globulin, which interferes with your ability to use hormones. It's not a complete block. Your body knows how to use sex hormone binding globulin, use the hormones on it, but it's a limited kind of absorption.
Yeah, and we see this high in, I mean, I was on of contraceptives for decades, and so my sex hormone binding globulin, even a decade after, is still too high, and I take boron, intermittently at least to try and keep that sex hormone binding globulin down, so that the little amounts of hormones that I've got left have got,
You get
can be
more.
utilized. Yeah.
Yeah, actually, boron helps dissociate the hormones from the binding globulin. One technique you can also use for high sex hormone binding globulin is add androgens back. They're the
Mm.
most tightly bound, but potentially if you add some DHEA, add some testosterone as supplementation, you can maybe bring that down a bit. At the same time, you have to make sure that estrogen's under control, because that's persistent, makes you want to make more, and your cortisol's under control.
Yeah, it is complicated, right? It is. And then your testosterones can aromatase into your estrogens as well.
Right,
And then
right, exactly.
what pathway are you putting those estrogens down, the 2-OH or the 4-OH or the 16? Like which pathway, and then how are you methylating it? So it's not a simple thing. But I think, like if we bring it down to people listening who are dealing with symptomology, so if we look first at young girls who just, maybe in the early years of their cycles and what they might be dealing with. Are you seeing progesterone as being a problem in those very young girls, say 13 to 25-year-olds, even with those
Yeah.
young ladies? Yeah.
Yes, and that's where I started, and they need a lot of progesterone.
Wow.
And this is kind of interesting too. So Katarina Dalton really triggered into that arena. And you can get violence, rage, anger, suicide, murder. It can be
Wow.
so severe. Interesting enough, in the luteal phase, second part of the cycle, from ovulation to bleeding, progesterone's going up pretty much in a nice big abundant bunch of progesterone. But what happens is this luteal cycle's got two parts. The
Mm-hmm.
first half of it is where progesterone supports the estrogen stimulated endometrial buildup, and in anticipation of a fertilized egg. When this doesn't occur, and this is mid-cycle when progesterone should be at its very, very highest, that it becomes a secretory hormone and changes that tissue so you can shed it. It's progesterone allows you to shed it. Okay.
Yes. Yep.
Okay, so you're shedding it. Now, some women have these PMS type symptoms 1, 2, 3 days into bleeding. It's
Mm-hmm.
okay to use the high amounts of progesterone there. Progesterone does not have to drop for you to bleed. And
Wow.
we are all taught this, and it's causing so much confusion when women are dosing with progesterone. For instance, I talked to a poor woman a couple days ago. Her doctor started her on some estradiol and progesterone, and she had a big bleed,
Mm.
huge bleed. And
Yep.
so they said, stop everything, and come in here. And they put her through thousands of dollars of tests.
Yeah. Yeah. Cancer tests and all sorts.
Yeah,
Ultrasound. Yeah.
exactly. And you know what? It's entirely predictable. You
Right.
start progesterone and you have some endometrium built up. At some point, you build up enough progesterone activity to make that layer sheddable. And
Mm-hmm.
it's going to shed. You're going to bleed. And good deal. You want it
Yep,
out of
that's fine.
there.
Yeah, like I've been dealing with that since I've been learning your work. I've increased my progesterone levels, and I'm also on testosterone, a small amount of DHEA, some pregnenolone, for the whole picture, and a tiny amount of estrogen as well. And I'm having regular bleeds now, probably a little bit too regular, like every couple of weeks regular at the moment. And I'm
Uh-huh.
still trying to play around with the dosing, right? Because I think I need more. I'm at 500 milligrams a day, which is
Mhm.
considerably more than what I was on 200, a la normal sort of protocols. And I haven't felt like I've reached that breakthrough point yet. And but I'm just going up carefully so that I don't, throw everything out of whack. But one of the main problems that I'm had is mood. Like I could kill people. Not literally, but I could just, irritability up the wazoo, uh, rage. That type of. I'll be honest. That's me at times, right? and very
Uh,
stressful life, very stressful life.
and
So
you
yeah,
need enough progesterone just to whip that away, and under
yeah.
an hour, that's happening. This woman said to me, she said, "Nothing my husband says bothers me anymore." Just like,
What, she's taking that much progesterone?
yeah, and that's what it should feel like,
Wow.
exact. And
Okay, I've got to keep going up then. I think I'm going to keep going up. And
so,
are there
just think,
downsides to that? Sorry.
yeah. Well, just think about what that does to relationships.
Oh, the amount of people that get divorced at 50 or 45 or 55 because, we're not tolerant anymore. We're grumpy. We're agitated. We can't sleep. It is really hard on marriages, and it's hard on women. And this is not being talked about enough. And, people think you've just changed, well, it's your hormones. And I often say to my husband, I'm trying to balance my hormones. Can you be patient with me? And he is, he's very good. But
Yeah,
it is quite violent, right? Especially when you've had such a mucked up history, as
yeah.
I've had, and probably years and decades of too lower progesterone levels. Do you think there is such a thing as stored up deficits, like from decades of being progesterone deficient? And, then you get to 50s and you're like, holy shit.
Yes, yes, and I think this is what's calling for some of the bigger doses of progesterone. If you were just aging gently, that 100, 200 milligrams may be just fine for you. Your adrenals aren't stressed, it's producing plenty of progesterone for you. That little bit of extra progesterone helping you sleep better, have less anxiety, no breast tenderness, all well and good. But there are women who, probably from birth even, were low in progesterone, and they have a horrible history of the PCOS, infertility, and
Fibroids and
PMS,
endo and
fibroids, this,
miscarriages is another
yes,
major thing.
miscarriages.
Yeah.
Yeah, and I've recently been thinking about this. I don't have any good evidence. I'll probably try to look for it. That nausea that you get, particularly in the first trimester of pregnancy, if you used extra progesterone, then would it not balance out that estriol? You have a surge of estriol happening, and the real big amounts of progesterone don't start till the second trimester when it's coming from the
Right.
placenta.
Wow.
And Katarina Dalton, I don't see that she mentioned it. Her severe PMS patients who are using large doses of progesterone, she continued on those large doses throughout the pregnancy. And then
Wow.
10 years later, scientists said she went and checked on the kids. And the kids were doing great. They were above their peers in their intelligence, and they were more socially adept. But they weren't excelling in sports. They're the same as. So
Same
I,
as, yeah. So it didn't make
yeah.
them, they didn't get more testosterone. Yeah.
No, no.
Thanks so much for watching, and we hope you enjoyed this video. Please like, comment, hit the notification bell and subscribe, and of course share it with just one person who you think could really benefit from this content. Click here to watch last week's episode, and click here for my website, and click here to watch a video you may not have seen yet.